Dr. Pranay, you can start sharing your presentation.
No question, sorry.
Yes. Audio clear, sir?
Yeah, can see your presentation.
Thank you.
Go ahead.
Good evening, ladies and gentlemen. I invite you to the ortho showdown of CR versus PS knees. Who can make the knee disappear? I'm Dr. Prannoy Paul, and let's get started. In life, success may not always mean that the other person is satisfied. When it comes to TKR, what is true success? Is it a perfectly placed implant on the X-ray? It just not should be the absence of just pain, but it's the absence of stiffness, clicking, instability, or any other sensation that feels unnatural. If you look at the traditional scoring systems like the knee society score or the Oxford knee score, they have something called a ceiling effect. This is where a large number of high functioning patients achieve maximum score on these scales so that we are not able to discriminate between a good outcome and a truly excellent outcome. So that is where the forgotten joint score 12 or the FJS 12 comes into rescue. This has no ceiling effect and it can capture even subtle differences in patient perception. It assesses the joint awareness during 12 common daily activities. So the higher the score, the less aware is the patient and the better is the outcome. So when we are doing a TKR, we should strive for a forgotten knee. What is a forgotten knee? The patient should move and the artificial joint should move and feel like a natural healthy knee. The patient should be unaware of the knee during daily activities. This is actually linked to the mental comfort and life satisfaction. So a forgotten knee is the epitome of functional success. So our goal is to make the knee disappear. So let us look at the pre-match analysis. In the red corner, we have the CR knee. The strength being it had preserved more bone, it has more natural kinematics, better proprioception, and the weakness is that it is technically more difficult and there is a risk of future PCL insufficiency. Whereas in the blue corner, we have the PS knee, which has a more predictable range of motion, easier soft tissue balance, and it is safe from a future PCL rupture. But it has a weakness of more bone loss and other things. So traditionally, we've been always been linking PCL with proprioception. We've been thinking that the mechanoreceptors and the innovation of PCL has been always been linked to better proprioception and a more natural feeling joint. So the hypothesis is that a CR design should provide a more natural knee. So today's match prediction is favoring more for the CR knee than the PS knee. But today's referee is going to be the FJS 12 scoring system, who is going to be a very tough referee. For the methodology, we did a targeted narrated review using peer-reviewed articles comparing PS and CR implants using FJS 12 as the primary outcome, looking at studies with levels of evidence 1, 2, and 3 in the last 10 years from PubMed and Scopus. This is the flowchart in which we went ahead and selected the studies and excluded some studies. So you can see the 7 studies that we looked at. You can see the number of patients that the studies included, the year of publication, the follow-up duration, and the results of these studies. The most recent study was in 2025 August, which was a systematic review and meta-analysis. So let us go ahead and do the analysis, PS versus CR. An unexpected plot twist. You can see that the PS knee has knocked out the CR knee in tonight's match. So the result is PS wins in tonight's match. The systematic reviews actually show that PCL preservation does not substantially improve proprioception post-TKR. PS implants were actually found to be superior to CS implants in terms of FJS scores. So this directly contradicts to the long-held theoretical benefit of PCL preservation regarding achieving a more natural feeling joint. So tonight's winner happens to be the PS knee. Now let us see why PS won today. A possible cause is that there is a study which mentions that after taking all the cuts and balancing, only 33% of the PCLs were actually intact. 43% were kind of attenuated, and 24% of the PCLs were effectively lost. So when PCL fails to function optimally, there occurs a paradoxical anterior translation of the femur over the tibia. This unnatural movement is subconsciously perceived by the patient and increasing the joint awareness. So how does a PS knee shines in this aspect? Here, the PCL is substituted with a post-cam mechanism. So PS designs can achieve more predictable and stable kinematics using their posterior rollback metabolism mechanism. So the idea might be that an artificial but a predictable stability might be more important than a natural but an unpredictable knee. But is today's verdict actually perfect? No. there exists extreme statistical heterogeneity across all the included studies, which means that the results might actually be affected by different study population, specific implant characteristics, or the methodologies used. Now, this is where things get actually interesting. If you look at the newer evidence, if you look at the studies comparing CR and CS TKRs utilizing highly precise techniques like kinematic alignment or robotic assistance, they found that there is no significant difference in the FJS scores between the two implant designs. So the new paradigm might be a precise execution like personalized component placement might be a more dominating factor overriding the design choice. So the real predictor, it's not the implant, it's the patient that matters. One recent study which looked at the high FJS scores after a TKR found out the criteria were a male gender, low BMI, and age somewhere around 63 years were associated with a high FJS scores after a TKR, and it was not related to actually the design choice. So what is the current evidence? If you are looking only at FJS scores from the recent studies, it actually shows that CS design is actually statistically superior. But this cannot be translated into a definitive general clinical recommendation favoring CS over CR. If you look at the traditional scores and survivorship, both designs have equivalent results. So we should focus on the quality of component placement, individualized kinematic restoration. This might actually override the trade-off between PCL retention and substitution. So the decision should actually rely on the surgeon experience and optimal intraoperative soft tissue balancing, looking at PCL viability. So the future of forgotten is precision. We should focus more on the surgical alignment, like component placement with precision, like robotics, and restore native kinematics. These factors may be more powerful than the CR versus CS design choice itself. So the future research, we need to resolve heterogeneity between the studies by doing more large, high quality randomized control trials, more subgroup analysis, and looking at the type of alignment to find the true differentiating factors. These are my references. Thank you for your patient listening.
Yeah. Thank you, Dr. Pranay. I'll invite the judges for questions.
So, Pranay, you have got some innovative PowerPoint presentations.
Thank you, sir.
Okay. So tell me, one factor where PS definitely scores over CR.
So one thing is CR knees, we cannot do CR in all kinds of knees. So if there is very gross deformities in extreme rheumatoid arthritis, or if the knee has some kind of previous trauma, then we definitely would have to go for a posterior stabilized knee. So the indications for a CR knee is actually limited. But PS knee, we have a more blanket criteria for PS knees. And so that is why one advantage of the PS knee.
No. See, there are some surgeons who also use only CR knees. Many surgeons, in fact, most of the surgeons, they are moving towards the CR knee nowadays. So, what the literature says about PS knee, how is it better, or PS surgeons, in what way they are better, and the CR surgeons, what way they are better? I'm telling patient-related outcomes measures.
Yes, sir. If you actually look at the evidence from the patient-related outcomes, it is actually same between the two outcomes. There is actually a study which was published in the article, the Journal of Neuroscience, which said that brain can actually adapt to a new processes. That is, if you look at the FJS scores at 5 years, and then you assess the same patient, the FJS score at 10 years, the score has improved, which means the brain can actually develop an adaptation to the artificial joint, and it can over time it can feel like a natural joint. But the only criteria is that it should have a predictable stability. If there is a predictable stability to the joint, then the patient can improve the joint awareness over time. So when you look at predictable stability, then a PS design can, because of its design choice, it has a more predictable stability. Whereas a PCL, if it's retained, we do not know how predictable the outcomes are going to be in the long run.
You told about testing the PCL intactness intraoperatively. How do you test that intraoperatively?
During the flexion and during the gap testing, we feel with our own hands for the tightness of the PCL and how viable the surgeon can feel by himself if the PCL is attenuated or it's in the right tension. So then he can intraoperatively take a decision whether to go ahead with the CR design or to go ahead with the PS design.
So physically you test it by pulling the PCL with a probe or something like that.
Yes, so we can use a probe. In our center, we actually manually feel it with our fingers, looking at the
Okay.
tension and the range of movement.
The third thing is patients with a high BMI. Would you prefer CR or PS and why?
We would actually prefer
More than 30, 35, say.
PS more because it has, like I said, it has a more predictable stability of a PS knee. This CR knee, we do not know. Sometimes it might give a good result, but it's a little bit of a dicey area. We do not know how predictable it is going to be in the long run if the BMI keeps on increasing, or if the patient has develops some other trauma in the future. We do not know how predictable it is going to be in the future. So that is why a more predictable design choice would be a PS in high BMI patients.
Thank you.
Thank you.